Global Medical News Network, I'm Heidi Spleet, reporting from the annual meeting of the American Association of Clinical Endocrinologists in San Diego, California.
Managing pregnant teenagers with type 1 diabetes presents both clinical and non-clinical challenges, Dr. Richard Guthrie explained. How does having type 1 diabetes have a unique impact on pregnancy?
Well, type 1 diabetes is, first of all, a very difficult disease, whether you're pregnant or not, whether you're female or whether you're male, and particularly when you're an adolescent. But type 1 diabetes causes a lot of problems in the pregnant woman because glucose goes across the placenta and into the baby. Insulin does not. So if her blood sugars are not well controlled, then the glucose is going to be high. The glucose goes across the placenta into the baby, and then the baby has to do something with that. The baby's pancreas will hypertrophy, produce more insulin to get rid of that sugar, has to go someplace. It goes into the baby's fat stores. Baby ends up big, heavy, baby plethoric in appearance. But also the high insulin levels in the baby retard the development of the baby's lungs. So even though the baby might be at term and might weigh 12 pounds, the baby's going to have respiratory distress. If the poor control occurs during the first trimester, when the baby is developing organs, they may have congenital malformations. They have heart abnormalities, they have cleft palate, they sometimes have hydrocephalus, they have spina bifida, and they have what's called a caudal regression syndrome, in which the legs don't develop well, the lower spinal cord isn't developed. So all of these congenital malformations can occur. If it occurs late in pregnancy, if they're not well controlled, they're going to have the big baby, the respiratory distress. So yeah, diabetes has a big impact upon pregnancy, whether you're a teenager or whether you're not. And it's particularly a problem in teenagers because they tend to be non-compliant to begin with. It's not fashionable for a teenager to be pregnant, but their bodies are also not quite ready for pregnancy. So we've got a combination of not only emotional but physical factors that make the diabetic girl, the girl who gets pregnant, a very difficult process and a very difficult thing to manage. But the outcome can be good. We know how to do it nowadays, so the outcome can be good, and you can get a nice, healthy baby, and that's an important part of it.
What are some of the clinical strategies for treating these patients?
Well, one of the clinical strategies is to, first of all, mobilize a team to take care of them. I think they're best taken care of in a team approach with a perinatologist, obstetrician, family physician, perhaps endocrinologist who knows how to take care of diabetes in pregnancy, plus the endocrinologist team of social workers, psychologists, nurse clinicians who can field their phone calls and so forth. These are very important organizational strategies that we try to take clinically to provide the maximum kind of support we can to them. Now, clinically, we also want to see them quite often. The more often you see them, the better compliance you will have from them, because they feel like you care and you're going to take good care of them, not be judgmental in that care, but to be supportive to them. We use always use multiple dose insulin regimens on them, follow their blood glucose monitoring, their laboratory data very, very carefully so that you can correct any problems that occur. Be aware of the changes that occur during the pregnancy because insulin requirements are a constantly changing phenomenon during pregnancy. So you see them often, you look at their patterns of their blood glucose control and make clinical changes in diet, in insulin, in whatever you need to do, as well as mobilizing the team and the social supports and communicating well with each other.